All right. Hi guys. Welcome to my video. And today, as you can see, I want to talk about ECG. Now, I don't want to make it too complex or too convoluted because there are textbooks for that. What I want to do is just take a small session about the basics of ECG and and just talk about how the ECG is produced, the basic vectors, the leads, and just breaking up the ECG strip part by part. What are the different aspects that you see on the ECG strip? Because nowadays on board exams and the USMLE especially, a lot of times you are given ECG strips with the clinical vignette. So you should be able to diagnose just a couple of things off the top of your head, like LVH, RVH, LBB, RBB, and myocardial infarction, because that's the most important thing. But on the other hand, I don't want to make it too complex, so I'll just make it very short. And if I am too slow, please speed the video up. And if any part is boring to you, just fast forward it. All right, let's get to it. All right, so this might, give a lot of people tachycardia just by looking at it, but we'll just piece it one by one, take one thing at a time. So what you should know about this strip is that each one big box is about 0.2 seconds long. Okay, and so 5 of these would be 1 second long. Right, about that much. Usually what you are provided, whenever you are provided an ECG strip, it's usually 10 seconds long. Usually. Now it doesn't have to be. It can be 6-second strip, it can be a 4-second strip, and it can be a 10-second strip. So the first thing that you should be able to do right when you get an ECG is talk about the rhythm. I'm not sure if I spelled it right. The rhythm and the rate. Now there are two ways that you can find out the rate. An easy way, which I do, is just look at the first QRS complex and then look at the second one. Now, if the first one, if the next QRS complex falls at the next, the subsequent line, it is 300. I'm sorry, it's 300. Then it's 150. Then 100. Then 75, and then 60 beats. So every one big box, it changes. So it goes, if you have one QRS over here, then if the other QRS was over here, then the rate would be 300. If the second QRS complex would be here and not here, if it was 2 boxes away, it would be 150, sorry. So a lot of people can do this. It's just very easy. For example, let's see, over here. So the rate between these two QRS complex would be 300, 150, 75, 60. So it would be around 60 beats per minute. Now another way to do it is you take the 10-second strip and you count the number of QRS complexes. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Now 14 into, you multiplied by 6 because it's a 10-second strip. So 10 into 6 is 60. So for 1 minute, you have to multiply it by a factor of 6. So 14 into 6 would be, my God, what would be, okay, 84. I'm not very good at maths. So around 84 per minute. All right, moving on. Now we talk about the specific, wave form of the ECG and the measurements. So the first we have is the P wave. The P wave, as you all know, is atrial depolarization or atrial contraction. Then we have the QRS. QRS is the ventricular depolarization and ventricular contraction. And the T wave is the ventricular repolarization. Now, the normal measurement for the P wave is about 2.5 small boxes. Okay, so the width is about 2.5 small boxes, and even the height should be roughly about 2.5 small boxes. Then QRS complex is also 2.5 small boxes. The PR interval, for example, should be around 0.12 to 0.25 seconds, roughly the PR interval. The PR segment is from when the P wave ends to where the QRS begins. That's the PR segment. Now this is the PR interval. PR interval includes the beginning of the P wave, but the PR segment includes the end of the P wave. So the P wave is 2.5 boxes. The PR segment is 2.5 small boxes. So what this gives you is the entire thing from P to S is roughly about 7.5 small boxes. So this whole thing is about 7.5 small boxes. And the rest of it is also 7.5 small boxes. So that's the rule of 2.5 or 2.5. So P wave 2.5, PR segment 2.5, QRS 2.5, and the entire ST is 2.5. All right. One other thing that you might like to know is the QT interval. Now the QT interval includes the ST interval plus the QRS. Now from here we know that the ST is 7.5 small boxes plus QRS is also 2.5 small boxes. So the entire thing is about 10 small boxes. Now one small box is 0.04 seconds. All right, so this 10 into 0.04 seconds gives you about 0.4 seconds. That's the normal length of the QT intervals. A lot of times when you're reading about medicine and cardiology, you will read about long QT interval syndromes. Long QT interval syndromes that gives you ventricular tachycardia and torsade. So you should know what a long QT means. A long QT is anything that is above 0.44 seconds in a male and about 0.46 seconds in a female. So that's just one thing that that's handy when you're looking at ECGs and you're given something in the clinical vignette, and it's just you can get the answer right like that. All right. I am getting a little off track with this, but I just thought that you would like to know that the causes of long QT are all hypo, a big O, okay? Hypo gives you long QT. That's how I remember it. So it's hypokalemia, hypocalcemia, and hypomagnesemia. All right, so just remember that whenever you're writing hypo, just make a QT, and it's a long QT syndrome. All right, now let's get back to ECG. Okay, now these are the leads which are used in the ECG. For example, when we go back to our, the strip, we see that we have lead 1, 2, 3, AVR, AVL, AVF, V1 to V6. Over here, we can see that we have 1 over here, 2, 3, AVL, AVR, AVF, and the chest leads, which are V1 to V6. Now, sometimes, questions will say V6, 8, and 9. And, as you go from the anterior to posterior, it goes from V6 to V7, V8, V9. So V7, 8, and 9, they're good to detect posterior wall MI. But you should just, right now concern yourself with V1 to V6. So what this tells you is that, the 2, 3, and AVF is basically telling you information about the inferior part of the heart. V1 and V2, both of these are septal. V3 and V4 are anterior, and V5 and V6 are lateral. So anytime you have ST elevation in V1 to V4, you will call it a septal anterior wall MI. So anteroseptal wall MI. V3 to V6 would be anterolateral wall MI. And I'll tell you, about the blood supply of these things momentarily. AVL is, AVL and AVR are the limb leads, and it is important about the directions of the vector. We will get into it, after this. Basically, what you should know is 2,3 AVF tells you about the inferior wall MI. This is septal, anterior, and lateral wall MI. Okay. So that's why the chest leads tell you about the location of the anterior septal and lateral, and 2,3 AVF is inferior wall MI. Okay, it's important to talk about the conduction pathway. Basically, the SA node is where it all begins. SA node is located at the junction of the superior vena cava and the right atrium. From the SA node, the electrical conduction goes to the AV node, and from the right atrium to the left atrium, because both of the atrium contract simultaneously, there is a bundle called the Bachmann bundle. It basically goes over here. It's the Bachmann bundle. It helps both of the atria to contract simultaneously and together. Now, as you might notice that the AV node is located, the orientation is horizontal, and it's that's important because you don't want the impulse to travel through the AV node very fast. If it travels very fast, then the ventricles will contract simultaneously with the atria, and that's not very good because it'll just push blood from the ventricle to the atria back in this direction, because this valve would be open at that time. So what you want to do is have a little delay so that when the atria is contracting, the ventricles are resting, and the entire blood will give time to the ventricle to fill during diastole. So that is important, that the AV node is horizontal. It slows the conduction time. AV node is the slowest I'm sorry. AV node is the slowest part of the conduction system, and you need that because there are arrhythmias which bypass the AV node, and sometimes it leads the ventricle. It causes the ventricle to contract simultaneously with the atria, and all the blood just rushes back here, and that's not very good for you. Okay, so after the AV node, the current passes to the bundle of His, and after that it goes through the right and the left bundle branch, and the left is actually divided into the anterior fascicle and the posterior fascicle, and you don't need to know that level of detail unless you're talking about fascicular blocks. So and after that we have the Purkinje fibers. The conduction velocities, I remember it through the mnemonic park at Ventura Avenue. Now the fastest fiber are the Purkinje fibers. Then we have the atrial fibers, then ventricular fibers, and then we have the AV node. AV node is the slowest path of the conduction system. That's what you have to know. All right, now coming back to our vectors again. This is really not important, 30 degree, 60 degree, 90 degree, you don't have to know that. What you do have to know is axis. So when you draw a line, sort of like that, over here, this entire thing is normal axis. Over here, this is left axis, this is right axis, and this is northwestern axis. The normal axis, actually, it extends from 90 degrees. It extends from 90 degrees all the way to, all the way to minus 30 degrees. So this, the entire thing. Let me just, get a different color. Green, okay. So this entire thing is left axis. Okay. And how you tell the axis based on the ECG strip, we'll just, okay, I'll just tell you right now. So what you do is you look at leads AVF and lead 1. Now over here you have lead 1, right? So this is the positive side of the lead 1 and this is the negative side. For AVF, this is the negative side and this is the positive side. The way you remember it is AVF is looking towards the feet. So if it's towards the feet side is the positive and the head side is the negative. So you look at the QRS complex. So if we go back to our strip, we look at the lead 1 and the QRS complex is it's positive. Okay, so we go back over here and we just cross it out. We are on the positive side, nothing on the negative side. We're on the positive side. If this is a little too convoluted, I'll just erase everything. All right. So when you're towards the positive side, you just shade it out that you are on the positive side. All right. So lead 1, the QRS was positive, and then coming back to AVF, even though it is very small, it's still considered positive because the negative side is very small, the positive is longer, so we'll consider it as being positive. So over here, we are on the positive side, so we'll shade the positive side of the AVF. Now, where the overlap happens is your axis. Okay? Let's say the AVF was, like this, and lead 1 was like that. So what we will do in this scenario, let me just erase it, is, okay, AVF is a little on the negative side, so we'll just, this is the positive side and this is the negative side. We'll just shade the negative side. And 1, the QRS is positive, so we'll shade the positive side. So this is where the overlap happens, so this is left axis deviation. So that's how you tell axis deviation. You just look at 2 leads, 1 and AVF. Okay, now moving on to the second part. Now if you guys have questions, please comment below and I'll address them separately.